Okay. Thank you, Lauren. So hopefully everybody got either a task or a closed captioning figured out. So to our online colleagues, hopefully you can hear me. I think I saw a comment there that the sound from the mic was a little distorted. So if you can hear well, Lauren, I think you can let us know, and the IT folks here can stop that.
We can hear you. It's just a little bit fuzzy, just to let you know. There's a bit of feedback.
Okay. Is it better now?
Yes, that's great.
Thank you. So my name is Sophie Fay, and I'm a project management director with Apt Associates. It is my pleasure to be sharing this session today with distinguished guests and speakers that I will introduce to you in a moment. But again, welcome to everyone. Migrant and mobile population, including refugees, internally displaced, or cross-border communities, face higher risk of morbidity and mortality. Several of those factors are poverty, social exclusion and discrimination, restricted legal entitlement to health and social services, language limitation, low health literacy and absence of permanent residence, among others, all of that exacerbated by the COVID-19 pandemic. So as countries accelerate momentum towards universal health coverage, these complex challenges need system-wide and multisectoral approaches to ensure that health services are responsive to the unique needs of these populations. In this session, we will share experience and learning from government, donors, researchers, and development partners, leading health system strengthening effort to improve and expand healthcare access for mobile population and migrants. This includes better policy and regulation for information sharing and cross-border information, tailored service provision such as COVID-19 messaging and testing, and stronger social health protection. The session objective will be to facilitate knowledge and exchange among key global stakeholders to inform program design and implementation and spotlight the importance of mobile and migrant health in global development goals. And with that in mind, we are again very honored for you all to have joined us. And we're just happy to have a short poll, to just kind of know more about your experience and interest on this topic. So my colleagues from the online will just start the poll. Online, you can see a link, but if you're in the room, just scan the barcode that is on the papers on your tables. So you should then be able to use your phone, scan that, and access a short poll of just 3 simple questions for us to better know interest and experience of all of our audience here and online. So let's have 3 minutes for the poll. And if you're having difficulties, let us know. But hopefully it's straightforward. After the 3 minutes, we'll just all be able to see the results. So, looks like you guys don't have a paper. Everybody is able to access the pool? Okay. So, I'm just going to run quickly to get my phone for the 3 minutes. Okay. So Lauren, everything is going well online?
Yes, it is. It looks like we already have almost 20 votes.
Okay, good, good. Okay. So 1 more minute for the room to access the pool, and we can all see what the results are. So hopefully this is going to be helpful. I mean, we really want to be able to get to what we want to talk about, and these answers will be very helpful. So, okay. Here they are. So, okay, looks like several of the audience very familiar with the topic. And that's very helpful. So I guess it's gonna facilitate the discussion here. What about the other questions? Look at that, access to care. The first challenge that people think migrant and mobile population are facing. So that's great. We hear a lot about that and how it got addressed in the presentation that we will hear later. And question number 3. Oh, yep. So some combination of accessing the normal and regular health system and having, of course, a system that also takes into account specific health needs. So there too, I think you won't be disappointed. Hear more about it through our list. So thank you so much for taking the pool. It was great. I think it's very informative. Now, just before we get started, some announcement and just a little bit about the structure of this session. So we'll start our first hour with some presentations. We'll hear from our distinguished panelists. We'll first hear from Dr. Santino Severoni on WHO Global Initiative in Migrant Health and Mobile Population. Then Dr. Julian Alfredo Fernandez Nino will present on migration and health, lesson learned from low and middle income countries. Mr. Hailu Zelelau will then share about improving access to quality healthcare for pastoral and internally displaced population groups in Ethiopia. And then Dr. Juan Jose Roe will present on progress in the access to health, the Venezuelan migrant population in Bucaramanga, Colombia. And Mr. Alejandro Diaz will close our presentation with sharing about state investment in migrant health in the RAC region. Right? Then in the second part, we'll have Q&A and facilitated discussion. And this will be facilitated by Mrs. Kelly Saldana. Please hold your question for that part of the session. Online participants are encouraged to send their question through the chat because we are monitoring the chat. So we'll ask you, if you're in the room, please don't join the WebEx because it interferes with the IT equipment here. So just in terms of housekeeping, if you need to use the restrooms, you can just, when you exit the door, you can go on your right, and that's where you will find them. So now, without further ado, I'm just going to present the first speaker. So Dr. Severoni Santino. Dr. Santino is Director of the Global Health and Migration Program Office and at the Deputy Director General at the WHO headquarters in Geneva. He's a medical doctor, health economist, epidemiologist, and health system manager with 24 years of experience. Since 2000, he had held senior position at the World Health Organization European Office. Most recently, he established and led the public health aspect of migration work for the WHO Regional Office for Europe. And in 2019, he was appointed Euro Special Representative on Health and Migration. So Dr. Santino, over to you.
Thank you so much for your kind introduction, and good morning, good afternoon, good evening to everybody. It's a pleasure to be with you today, and a very interesting topic, quite complex. That's why I thought to put together some slides to share with you some of the findings, the most relevant findings, particularly in relation to access to health system for refugees and migrants, which we observe out of the World Report, the first WHO World Report on the health of refugees and migrants we published last July. So the overall picture is quite interesting because showing, let's say, a world on the move, if I can play with the words. We are not yet in an ideal situation. Still, the mobile population, migrants, refugees, particularly those in more vulnerable conditions like irregular migrants, asylum seekers, are still heavily falling out from the health system protection and access to essential service. The first slides, please. I think it's important, next one, please. I think it's important to immediately size the matter. I think all of you are pretty familiar with numbers. The numbers you see there should be completed by internal migration, previous please, by internal migration movement. So we should consider that we are speaking, when we are talking about population movement and the health aspect of the population movement, we are speaking about 1 billion people, 1 on 8 in the world population. Next one. The topic is highly political sensitive, often polarizing. We all see that and experience that in our daily work for a number of reasons. So we dissected, we analyzed the multisectoriality, which is a benefit in many aspects. In reality, also is at the base of political confrontation and different agenda confrontations. Mostly on daily basis, what we are observing all over the world in most of the country, a competition for securing access to health and implementing of security measures, or protection, enjoyment of human rights versus national regulation, which they tend sometimes to override essential human rights. This mostly because the political actor around the table are pretty some. Next one, please. Just to draw on the report, and in a complementary study done during the initial phase of the COVID pandemic, we immediately thought important to verify what is the policy setting worldwide of all our member states. So we launched a review of the policy setting to explore if they were including or not refugees and migrants in the COVID response measure. And what we got was quite interesting, because in one hand, we observed that the pressure of the pandemic has been inspiring many countries, about 1/3 of the countries around the world, to have a well-consolidated, rational public health approach, means an inclusive approach, really try not to exclude any from the population. Most of the country adopted a temporary solution. They launched exception to their own legal framework in order to eventually implement a pandemic response, but then to go back to the previous conditions. This mostly for the political choice and political setting in those countries. Next one, please. The overall picture with today, when we are looking at the policy setting and how it's related to the legal framework, determining the level of entitlements or access to the health sector, and precisely the level of coverage, what we call the universalistic approach, the universal coverage approach adopted by country, can be basically simplified in a pyramid stratified in 3 levels, where minority, 1/3 of the countries, tend to have a universalistic approach with a lot of but, because in reality, barriers, they are still playing a very important, barriers in access, they're still playing an important role. And then a middle group, which tend to offer emergency services and something more, and a group which basically tend to exclude almost voluntary because of the legal framework restricting access, especially for this population, which is in the gray zone of transit from regular irregular situation. Next one, please. As I said, there is a very important role played by barriers. We all know that. With the report, we highlighted these 6 main reasons for obstacle in building barriers in accessing the health systems and enjoyment of services. We tend to divide them, to classify them in 2 big groups, voluntary or involuntary, or direct or indirect. Basically, the indirect or involuntary are all those conditions related to system functioning or dysfunctioning of the system, like I'm going to show you in a second, versus a political decision, a political choice to have a restrictive policies, to have a restrictive policy framework in order to limit theoretically the health spending for a population which is not a national population. Next one, please. The case of access to COVID vaccine that we monitor and study during the pandemic and including the World Report was emblematic, in fact. Again, we decided to analyze, to study the situation in relation to 104 countries participating to the COVAX initiative. And we went to analyze the national deployment vaccination plan for those countries. And in early stage of the vaccine rollout, we observed a pretty limited inclusion of migrants and refugees, even if the feedback from the countries said, no, yes, of course, this is for the entire population, but this group of population were not explicitly mentioned in the plans. And this is a problem because they cannot be addressed because of the legal framework. They cannot be addressed, or we can elude ourselves that just mentioning inclusion of vulnerable groups, we can overcome the legal framework or existing other barriers in access. So there was a quite intense campaign of sensibilization. Later on, 5 months later, we analyzed again the package of national deployment vaccination plan. And as you can see from the in bold figures, the situation substantially changed, where 75% of the plans analyzed were including refugees in a clear manner, regular migrants 84%, situation remaining very concerning about those in more vulnerable conditions, those which are in irregular situation. When we think about migrant in irregular situation, we should not think only those which are crossing irregularly the border. In reality, this population is made by many people that for a number of circumstances, they might lose job or they can end up into falling into the crack of the system and losing their rights to access essential service. Next one, please. We analyze what were the main causes to access the vaccines. And interestingly, you can see in the graphic on the left side, the reasons, this by analyzing 62 countries, 42 low, middle income and 20 high income countries in implementing the vaccination plan for COVID. And as you see, limited information, administrative barriers, language barriers, fear for the vaccine, but also concern about possible risk for deportation or existing functional obstacles or imperfection in setting up the health system rolling out modality has been playing a very important role. On the right, you can see the different bars showing and comparing the level of access confronting the black bar irregular migrants and the blue one regular. What was the situation in the WHO globally divided by regions? Next one, please. We also thought to reach out refugees and migrants. So we ran a survey still during the hot phase of the between the first and the second wave of COVID. We interviewed 30,000 refugees and migrants worldwide from more than 130 countries around the world. And it was interesting to explore what was their perception of safety and access to health. Interestingly, and a confirmation, unfortunately, have been that financial constraints are playing a very, very, very impactful role in postponing, procrastinating, or even renouncing to refer to the health system. This was the case for 35% of the interviewed, while 22, the fear of deportation. So this is linking directly with the legal framework the countries are utilizing, was also playing a very important role, even in presence of COVID signs, symptoms within the family or the interviewed person. The mental health aspect playing a very important role. There is a lot of talking about mental health, but in reality, more study, more research need to be done in this area. And almost 50% of the interviewed reported the deterioration of their mental condition, even reaching the situation of starting using drugs and alcohol. This was the case of 1 on 5. Next one, please. All this is manifesting, and we use the COVID situation to really learn a lot. And COVID was also playing a very important acceleration, booster effect, let's say, in promoting an inclusive approach. Now the question is not to move back from that. And the support, the policy landscape supporting the interventions, probably we should say that never like now we are having such solid policy framework and clarity of what needs to be done and how things are supposed to be put in place. Migration is really on top of the all policy and political agenda worldwide, globally, regionally, and nationally. So it's a time probably that we need to start to focus in evaluating the cost of action again vis-a-vis the cost of not intervention or not action. There are some, again, technicalities which are playing a negative role. The element of migration is heavily represented in the SDGs. Although when we look at the SDG 3, and on the right you can see the number of indicators which today are guiding the monitoring of progress in implementing migration elements within the SDG, it's pretty rich set of indicators. When we go to the SDG 3, we don't have any specific indicator. We are still working mostly with proxy and through the target of SDG. This is a gap which needs to be certainly fulfilled. From WHO side, we have a global action plan which is framing the action that the organization is promoting in order to stand by and support better access and understanding of the public health aspect or health and migration overall issues with member states. And the last one to conclude, we are, of course, very, very committed as a WHO to move on the agenda of related to the health and migration, the health aspect. I'm underlining health because the two words, health and migration, might sound misleading. As a WHO, I like to say that we don't know anything about migration, but we know very well what are the health sector and health system implications related to population movement. So the report I mentioned to you, we just launched the first ever in July, where if you like to see more, it's available free access on our website. And this is going to be a production that we're going to continue to release every 2 years and refining, improving the data that we're going to utilize for that. We have a data initiative. We are suffering still an issue of quality of data, quality research. In fact, data initiative and research agenda are also the two important areas of investment of the organization, together, of course, with a technical assistance to countries and normative law. Thank you very much for your attention, and happy to get any question, if any.
Also, as we can see, most of what we identified as.
Sorry, the mic is not pulling through for remote staff.
What we identified as constraint came again. So thanks for that. Next, we'll move to Dr. Juan Alfredo Fernandez Nino. So Dr. Fernandez Nino obtained his Master of Public Health, Master of Science in Biostatistics, and Doctor of Science in Epidemiology from the National Institute of Public Health of Mexico. An educator and researcher by profession, he has held position at the Industrial University of Santander and Universidad del Norte in Colombia. He also served as the National Institute of Public Health of Mexico, and from July 2020 to March 2022, he was the Director of Epidemiology and Demography of the Ministry of Health and Social Protection in Colombia. He is currently an assistant scientist at the Johns Hopkins Bloomberg School of Public Health. So, Dr. Fernandez Nino, over to you.
Hello, everybody. I'm very thrilled to be here. It's an honor to share this space. So today, please, we can start the presentation. Next slide. Okay. Today, I would like to speak a little bit about the complex relationship between migration and health, but especially I will focus on some lessons learned from low and middle income countries globally, which in the last year have started to be receiving countries of migrants. Next. Dr. Santino already presented some numbers. I'm not gonna go deeper, but we know that the number of international migrants has increased in the last years globally, but I would like to show you that actually in both regions, Latin America and Asia, the numbers of international migrants have increased in relative terms significantly. And that is important because I would like to highlight that in the last years, in the last decades actually, we have observed a very significant increase in the number of low and middle income countries that now are receiving countries of migrants. That's the case of Colombia, of course, and that is important because these low and middle income countries have less experience as receiving countries, but also their healthcare systems used to have less capacities, and the challenges definitely are different for this we can call south-to-south migration. And next, please. I would like to show you some key ideas. I don't have enough time to go deeper, but I think that it's important to mention some of them. First, migrants are definitely a heterogeneous group. That is important because considering that migrants are diverse, their health needs are diverse too. So we're talking about many different subpopulations and with different contexts, with different social determinants, and that explains that we have different challenges for the healthcare systems. Second, when we talk about migratory policies, I am sure that actually protecting life and protecting the health of migrants is one of the most important challenges for any host country. A third idea that is also important to highlight is that migration is not necessarily a cause of disease. Some conditions of migration, especially when it's forced and irregular, could affect health, of course. But it depends on the kind of migration, it depends on the context, and even in some cases, some migrants could improve their health due to the migration. It's also important to consider that the condition of migrants change very quickly, and we need to understand how the health change over time. Consider these changes in the throughout the migratory process. So probably the classic origin transit destination model is insufficient to understand these new mobilities, such as the south-to-south migration. As I mentioned before, the challenges are different, and south-to-south migration actually have a lot of things to teach, even to the high-income countries which traditionally have been receiving countries. And finally, I would like to mention something that is important, is that we are observing a feminization of migration worldwide, and it represents a challenge for guaranteeing reproductive health and also to protect women and girls from sexual violence. Next, please. Oh, okay, there are a lot of myths that is necessary to debunk regarding migration and health. I'm not going to go deeper here, but it's important to remember that it's not true that migrants are a burden on health service. That's not true. Also, it's not true that migrants are not disease carriers, at least no more than other local groups. It's definitely false that migrants are damaging economies. So it's important to consider that migration is, of course, a challenge for healthcare system, but we can't see that like a burden because it's not a burden. Actually, it's an opportunity to improve the healthcare system and the healthcare access, the access to health services. Next, please. Okay, here is a very simple model, but it's important to highlight some basic ideas. First of all, that the relationship between migration and health is bidirectional. Migration could affect health, but I said it depends on the condition of migration and even could affect in a positive way, but also the condition of health could determine the need of migrate for many people. So when people in the middle of a crisis, especially in the middle of crisis, are not receiving medical attention, they could decide to migrate. And also, we have to consider that there is some minimum health conditions necessary to be able to migrate. That is the reason because most of migrants are young people with low prevalence of chronic diseases. Of course, it could change in the middle of a crisis, like the case of Venezuela, in which some people with some disease or even pregnant women decide to migrate in order to get better access to health services. And finally, we have to consider, if we see this third box, that there are some conditions which are co-determinants simultaneously of migration and health. So when we study the health of migrants, we have to consider that the conditions which could make them to migrate are also related with their health, like poverty, income, and others. Next, please. This is a little bit more complicated framework, but I just want to highlight here that when we study the health outcomes among migrants, we have to consider that we have very high-level social determinants, like the socio-political context. For example, in the case of Colombia, some of us are concerned about how the political change in the migratory policy could affect the health policy for migrants. That is important because the socioeconomic context at the regional level, but also at the national level, is very important. And here I would like to highlight that regularization, I mean migratory regularization, is an important determinant because the regularization of the migratory status allows, or at least increases the chances of improving the income, the housing conditions. Of course, affects a lot of determinants of health. So, regularization is essential to understand how we can, moving forward, in the need to guarantee the health to psych for migrants. I don't have time to go deeper here, but I think that we can see that it could be more complicated, of course, if we can consider different determinants. Here we have some strategies proposed by WHO. Dr. Santino already talked about that, but I would like to highlight the first one because I think that there are a lot of things that we have to do in this issue, that is the one related with monitoring migrant health. It's necessary to have better information, but also research about the health conditions among migrants, but also we definitely need to understand how these new mobilities affect health in the different moments of the migration process. And also, we need to design and evaluate as well new interventions for migrants and for different kind of migrants, like pendular migrants, like migrants in transit that are different to other kind of migrants who stayed in the host country. Next, please. Okay, just like an example, there are some studies that we have carried out in Colombia, but as well in Mexico with Dr. Iexabo Jorquez. In the last year, for example, we have compared the health policies for international migrants between Mexico and Colombia. I think that now it's so important to understand how these health policies will change with the political changes that we are observing in all the countries in Latin America. It's important to understand the relationship between healthcare systems, models, but also migratory policy and the health policy for migrants. Also, we have a study how some migrants, like pregnant women, navigate in the healthcare system in Colombia. There is a qualitative study that you can find, and that is an example of what we can do. Of course, we can do better. Next. And Dr. Santino also spoke about that, but I would like to say that definitely COVID-19 was a litmus test for public health, and especially for the health policy for migrants. In Spanish, we would say una prueba de fuego, and we can observe here this very interesting study about the inclusion of migrants in the national vaccination plans against COVID-19. And now with Dr. Iexabo Jorquez and Dr. Maylen Rojas, we're working on understanding how the structure of the healthcare systems determine or are associated with the decision of inclusion of migrants into the national vaccination plan against COVID-19. Because it's not just important to understand if they were included or not, but the reason because it happens. Next, please. Okay, I'm gonna finish mentioning some lessons that we have learned from low and middle income countries. Of course, some of them also apply worldwide, but I think that some of them are crucial in our context. First of all, I definitely think that we need to transit for a model based on emergency response to another model based on institutional strengthening. It's so important. At the beginning of the crisis, 5 years ago, I'm talking about the Venezuelan migration to Colombia, it was addressed like an emergency crisis. But now, more than 5 years ago, we need to understand that like a long-term need of institutional strengthening. I don't think that is necessary to create different policies or different plans for migrants. Of course, there are some cases like emergencies in which you need a specific intervention. But I do think that what is important is including migrants in all the public health strategies. So we are talking about integration, inclusion, that is different. And also social, economic, cultural inclusion contributes to improving health. Not just the regularization of the migratory status, but all the policies to integrate migration into societies are essential to guarantee the health of life for migrants. So regularization of migratory status is status is so important, but fortunately, the intervention of public health, at least I think that they are not linked with the migratory status. Public health intervention have the possibility to benefit everybody in a country. So there is an opportunity to collective intervention, which improve the health of migrants, but also of the receiving population. Next. Certainly, mental health, human security, gender-based violence, and sexual and reproductive health must be priorities. And of course, we need actions beyond the healthcare system in order to protect, for example, for instance, migrant women from gender-based violence. I just mentioned that there is a complex relationship between life course and human mobility, and I would like to mention again that a different approach is required that considers the different types of migration and the receiving community. Improving the healthcare system for the most vulnerable people in communities, we are also improving the healthcare system for migrants. So it's not about create a different plan or a different healthcare system for migrants, but including migrants in health, public health action. And finally, a health emergency like COVID-19 cannot be responded without including migrants, not just because it's fair, but also because it's impossible to control a virus transmission if you don't include migrants. Next one. And the last sentence, I'm gonna say that in Spanish because I think that is an important message and definitely smart in Spanish. Las políticas de migración tienen que ser definitivamente políticas de Estado. No pueden ser instrumentos de la lucha geopolítica regional, como pasa en la migración venezolana en Colombia, en donde se han interpretado erradamente la inclusión social, económica y cultural de los migrantes es un imperativo ético, pero también beneficia a las sociedades. La migración tiene que ser transversal y tiene que ser una política de Estado que trascienda las diferencias ideológicas de los partidos políticos. Muchas gracias. Thank you very much. I'm very glad to be here.
It was interesting to hear. We'll now move to our third presenter. And we're here from Mr. Hailu Zelalau. Mr. Zelalau is a project director, health policy, health economics advisor with APT Associates. At APT for almost 2 decades, Hailu provided technical assistance to project and host country He is backstopping several of the global and bilateral projects at APT, specifically programs in Ethiopia. He's also managed some program in Africa. And in 2013, he is a recipient of the Clark APT Prize for Outstanding Social Impact. So, Shiloh, over to you.
Thank you very much, Sophie. My presentation focuses on our practical field experience in Ethiopia for the last 2 decades, supporting health financial system strengthening through subsequent USAID projects, and also more recent support in pastoral areas, and even more recently in the last couple of years, helping revamping and strengthening of the health system in conflict-affected regions and areas. Next. So as I mentioned, this is from our field experience, and the credit goes to my colleagues in the field, many of whom are attending also this session, and I'll focus again on pastoral and displaced people in Ethiopia. Next. To give you a highlight of Ethiopia, Ethiopia is located in Eastern Africa, also known as the Horn of Africa. It's relatively sizable with 1.1 million square kilometers, or around 386,000 square miles. It has a population of close or over 120 million, and the GDP, as you can see, is relatively low. Coming to the pastoral areas, as you can see from the map, the Somali region in the southeast, and also the Afar region in the northeast, as well as parts of the southern region in the southwest, and the southern part of the Oromia region are also resided by pastoralist communities. In Ethiopia, we have a total of 12% of the population counted as pastoral or semi-pastoral, and these pastoral areas account about 1/3 of the geographic area. When we come to conflict, as some of you might have heard, in the last 2 years, we have serious conflict in the northern part of the country, which affected eastern part of Amhara and northern part of Afar and the entire Tigray region. Additionally, we have also conflicts in some other pocket areas in the western Oromia and Benshangul Gumuz region, again in the west. Next, please. To give you a brief financing background or context in Ethiopia, health generally is underfinanced. As you can see, the per capita spending in health started from the very low level of spending, like $4.5 per person per year. And even more recently, the recent NHA showed us per capita spending reached only around $36 per capita, which is still much lower than what is recommended by WHO. The other important aspect in Ethiopia's health financing is out-of-pocket spending and donor dependency are also significant. As of 2019-20, around 34% of the total spending is supported from or by donors, and households also accounting around 30% of the spending, and government covering 32% of spending the same year. Next. So Ethiopia in the last 20 years has been implementing both supply side and demand side reforms. From the supply side, the major reform area that we have is allowing health facilities to retain and use revenues at facility level, which is quite significant when it is additive to the regular government budget, and also aiming at improving quality of healthcare. By that, it means focusing on availing essential commodities to improve healthcare, including medicines, and also procuring and availing equipment and improving the working condition, working environment, including the physical condition, and availing essential utilities such as power, water, and other important elements for the health system to function. And from our overall understanding, the revenue retention is accounting around 26-25% of the total spending at health facility level. And as I said, this is significant when it is additional to the regular government budget. The other important area, which is also important in terms of revenue retention and utilization, is improving governance and also financial management. Regarding governance, health facilities are allowed to function as independent and autonomous entities, and they have also their own governing boards, which ensures there's accountability and also proper functioning. The other reform areas, including systematizing and improving the few-ever system, which is more of providing free healthcare access to the poorest, and the exemption of some of the health services which are considered as essential public health services, including immunization and treatment of like tuberculosis, HIV, AIDS, and other family health related primary services. There are also hospital level services, including allowing public hospitals to function like a private like facilities in some aspects, and also outsourcing of non-clinical services so that public hospitals can properly function and focus in their technical areas of providing clinical care. The demand side reform area, which is relatively new and expanding quite extensively in the country, is to provide financial protection for the large segment of the population. I'll come back to that again. And community-based health insurance is the most important aspect of the financial protection as it stands now currently. Next, please. When you come to the pastoral regions, those regions that I mentioned earlier, there is limited institutional capacity, I mean, from supply side, and human resource capacity is also limited generally in the country, but more particularly in those pastoral regions. Physical access to health facilities and health service providers is very limited. As you can imagine, and as I mentioned earlier, 1/3 of the country is covered by these pastoral communities, and these communities account only 12% of the population, which is large in terms of number, but when you compare it to the landmass, the settlement pattern is very scattered, and access to service is very limited and actually very challenging. Because of that, as you can imagine, health service utilization is very low in those regions. Yes, revenue retention is being practiced in many of the health facilities, but adequate budget for covering those exempted free services is lacking overall in the country, but also particularly in those regions. Staff turnover, including leadership, is very high in those regions. And also governing boards, as I mentioned, are critical for autonomy of health facilities, but there are very many competing tasks. Sorry. Very many competing tasks, and regular attendance of board meetings is rather a challenge. When it comes to the demand side interventions like the community-based health insurance, as I mentioned, because of low level of utilization, demand for joining like the community-based health insurance program is rather very weak. As you can imagine, the pastoral community is very mobile, and CBHI as it stands now is providing services based on catchment to health facilities. And because of mobility, I think the recent lesson that we learned is there is a need to allow portability of benefits, particularly in those areas, and also having given multiple ID cards. Now we have only one ID card per family, but going forward, the idea and the thinking is to have more family ID cards so that the mobile group of the population can use other facilities outside the catchment area. Poverty is high and targeted subsidies are equally critical. Next, please. Supply side reform, especially in Somalia and Afar, started more recently, around after 2010, but more aggressively since 2013. So implementing those revenue retention and utilization, the facility governing board and other aspects in those regions is relatively recent phenomenal. Similarly, community-based health insurance, as you can see from the top bullets, it started some time ago, but in this pastoral communities, it's relatively more recent phenomenon, and we have only limited CBHI schemes in selected woredas, like in Afar, out of 40 districts, woredas means districts, we have CBHI only in 5, and in Somali, out of 99 districts, we have only CBHI only in 4. Next, please. When we see the facility revenue retention utilization in pastoral regions, only 73% in Afar and only 16% in Somalia are implementing revenue retention and utilization. Only 52% of health facilities, again in Afar, and only 16% in Somalia have governing boards. And in Oromia and the southern region, the pastoral facilities or pastoral areas have better functioning of those reform areas. Generally speaking, the first generation reforms improve local accountability and responsiveness because partly governing board members are also represented by local communities. Availability of essential medicines, we see even in those regions and facilities is improving, and relatively speaking, professional satisfaction is also improving. Next, please. When it comes to the enrollment rate, by enrollment, we're talking about more the eligible groups where in the woredas or districts where we have CBHI. The pastoral communities like Afar and Somali are relatively late starters, as I mentioned, but also enrollment, even in those districts, is relatively low compared to other regions, as I mentioned, is related because of different factors. But again, community-based health insurance is improving health service utilization among those enrolled, and definitely improving financial risk protection, improving equity, and empowering women to access services without waiting decision from their male counterparts. Next, please. When we come to the different shock and stress affected areas, in the last few years, we had locust infestation in some areas, we have conflict in different parts of the country, and COVID, as you know, is a global phenomenon. And when we see that, like COVID and locust infestation, like community-based health insurance was not significantly affected. But when it comes to conflicts, especially the full-fledged conflict in Tigray and parts of Amhara and Afar, it has substantially impacted the facilities, and there are very many displaced people, and also even health workers are displaced. So that is affecting access to health service. And in some of the areas, we are working on post-conflict rehabilitation, and we're doing like rapid assessment and working with different stakeholders on improving health system and functioning of those affected health facilities in the post-conflict regions. Next. Quickly to wrap up by summarizing the lessons, I think the first lesson is definitely pastoral communities can benefit substantially from both supply side and demand side reforms. Adjusting reforms to pastoral communities is definitely important, as I mentioned, in terms of portability of the CBHI benefit. Long-term technical assistance is critical, as these regions have rather limited capacity, and more targeted subsidies are required. And when it comes to the conflict-affected regions, post-conflict assessment and comprehensive response and collaboration of stakeholders to build resilience are critical. Thank you very much. Sophie, back to you.
Thank you, Hailu. Thanks for that presentation. Now, after our 3 online presenters, we'll now switch to the room, and I'll invite our next presenter. We'll next hear from Dr. Jose Rey. Dr. Juan Jose Rey currently serves as the Secretary of Health and Environment of Bucaramanga here in Colombia. Since 2014, he has served as the Dean of the Faculty of Health Science at the Autonomous University of Bucaramanga. He also serves as an epidemiologist at the Public Health Observatory of Santander, manager of the Bucaramanga Health Institute. Dr. Rey received his master in epidemiology from the University of Antioquia. He's also specialized in senior management and health administration from the University of Santander. So, Dr. Jose Rey, over to you.
Muy buenos días. Muchas gracias por esta invitación y qué bueno que podamos también desde las ciudades contar experiencias concretas de campo que complementen estas importantes presentaciones que se han dado desde lo global, desde los países. Bucaramanga es una ciudad de algo más de 600,000 habitantes, que queda relativamente cerca a la frontera con Venezuela, algo más de 150 kilómetros. Nuestro alcalde, el ingeniero Juan Carlos Cárdenas, tiene un eslogan que nosotros en Bucaramanga sabemos que tenemos un familiar, un tío, un abuelo, alguien que hace 20, 30, 40 años migró de Colombia a Venezuela a buscar una mejor vida. Tenemos un sentimiento de gratitud y deber moral para también dar el paso al frente en estos momentos. Nosotros venimos trabajando muy animados con el apoyo del programa de comunidades saludables, con USAID, Next Gigantes y Next. Ok, excelente. Y lo primero que hicimos fue una reflexión muy interesante de cómo estábamos en lo institucional, en la alcaldía, en la secretaría. Y nos encontramos con un panorama que ya nos han comentado. Tenemos prácticamente una actividad muy reactiva, muy de emergencia. Buscamos hacer cosas, pero realmente lo hacemos todavía muy desarticulado. Nos falta una experiencia grande como país, como regiones, para hacer una atención mucho más integral a esta problemática. Pero ese ejercicio nos sirvió muchísimo. Darnos cuenta y poder animarnos precisamente a hacer un trabajo de creación un plan de fortalecerlo y de tener una agenda mucho más dramática para atender desde lo que podemos hacer desde la salud, que es mucho a esta problemática de salud en la población migrante. Next one, please. Dentro de estos elementos de gobernanza y de políticas en salud, iniciamos una tarea de crear una mesa de trabajo para articularnos, reconocernos, orientarnos en términos de que hay muchas instituciones gubernamentales y no gubernamentales queriendo hacer cosas, pero muy desarticuladas. La autoridad sanitaria, como alcaldía, convoca, genera confianza y es el escenario donde creemos podemos plasmar y articular las actividades que vayamos a hacer. Pero también es una mesa que tiene una vocación de escucha. También veíamos algunos de mis asesores que nosotros no estamos teniendo un canal en materia de salud, de diálogo directo, certero con la población migrante. Y ahí necesitamos trabajar arduamente. Nos vamos a la tarea de elaborar un plan de respuesta. Tenemos ya un documento que contiene alrededor de 59 acciones concretas, con sus metas, con sus indicadores, y que pretende especialmente poder direccionar las dimensiones y las tareas que hacemos en materia de salud pública para que la población migrante sea tenida en cuenta. En el punto 3, hemos empezado también a elaborar, socializar circulares que nos permitan como autoridad sanitaria hacer un llamamiento y también desarrollar procesos o procedimientos que son importantísimos. Se mencionaba uno en donde Bucaramanga hemos avanzado. Necesitamos información, necesitamos tener el perfil epidemiológico, necesitamos que este tipo de poblaciones nosotros las tengamos en el radar, en el visor, y poder con información tomar decisiones mucho más efectivas. Necesitamos que los actores que trabajan en materia de salud en nuestro país son diversos, hay prestadores, aseguradores, hay muchas instituciones, ellos incluyan a la población migrante dentro de sus programas. También digamos en el punto 4 un trabajo de sensibilización hacia lo que es la atención con equidad, con inclusión, porque tenemos muchas personas, funcionarios públicos o que trabajan en instituciones de salud que no están atendiendo de una manera adecuada, con un criterio realmente de equidad y de sensibilidad social a esta problemática. Iniciamos unos espacios de diálogo y de articulación con las organizaciones de base, los migrantes, a entrar, a tener, repito, una posibilidad de crear muchos de los temas que se han venido desarrollando. También un curso de liderazgo para la gestión del cambio que se ha venido impartiendo también desde el programa de comunidades saludables, los funcionarios de alto nivel que puedan estar desarrollando esas capacidades humanas para que podamos nosotros tener en todas las instituciones de salud voceros y personas que nos ayuden a lograr este cambio. Next one, please. Dentro de la promoción del financiamiento, nosotros creemos que Colombia tiene una gran oportunidad con su sistema de salud. Es un hito que tiene un plan de beneficios interesante y nuestro afán en un principio fue filiar a los migrantes a nuestro sistema de salud. Y ahí empezamos a buscar paso a paso cómo reducir barreras, cómo llegar a difundir el mensaje de que el migrante puede acceder y tener el seguro de salud colombiano. Estaban muy desinformados. Tuvimos que desarrollar muchas estrategias en el paso a paso, en llegar donde ellos están, a sus asentamientos, trabajar mucho con Migración Colombia, con todas las instancias que nosotros pudiésemos tener para afiliarlos, aprovechar la urgencia en salud para que en ese mismo momento de la atención se pudiese llegar a afiliar a la persona. Los resultados nos tienen contentos. Como ustedes ven en el cuadro, llevamos 17.741 migrantes afiliados al sistema de salud y creemos que financieramente el sistema debe acogerlos. Debemos nosotros, y en Bucaramanga lo tenemos aprobado por nuestro Consejo de la Ciudad, un presupuesto en UPC, como se llama la financiación al sistema de seguridad, que puede albergar e incluye más de 25.000 migrantes para que accedan a la seguridad social. Next one, please. Desde el punto de vista de la calidad de los servicios de salud, hemos venido sobre todo trabajando en las primeras etapas en lo que tiene que ver con el talento humano y se ha trabajado en varios frentes. Resalto algunos que son muy interesantes. Nosotros en todas estas instituciones, actores que prestan servicios de aseguramiento, hemos venido trabajando con las personas que están en la línea del frente, con la persona que atiende directamente a ese migrante, formándolo. Porque nosotros lo primero que necesitamos hacer es que nuestra gente entienda el problema, se sensibilice con él y obviamente tenga la posibilidad de darle ese trato a la persona que lo necesita. Hemos estado también trabajando nuestro equipo de participación social en la alcaldía, colocando este tema realmente en el sitial que merece. La población migrante, repito, ha estado, se sabe, tenemos el problema, pero necesitamos que en todas las agendas del gobierno y de las actividades de salud siempre exista. Entonces, colocamos este tema de la atención al migrante en nuestros equipos humanos que están haciendo el trabajo de participación comunitaria. Un tema que ha sido realmente de resaltar, a mí me ha impactado bastante en lo personal, es el fortalecimiento del compromiso ciudadano y comunitario. Cómo llegamos a los líderes, a las comunidades de acogida. Hemos invitado a voceros muy representativos también a que se formen dentro de las estructuras de vigilancia comunitaria, pero sobre todo en una forma de decirle a nuestros ciudadanos, a nuestros conciudadanos bumangueses, que ellos también tienen una labor de salud, de promoción de la salud que hacer en aquellas comunas donde tenemos también asentamientos de migrantes que tienen vocación de permanencia. Y finalmente, la implementación en una ayuda que sabemos es un poco más a mediano plazo, de que podamos contar nosotros con el mejoramiento en la calidad de los servicios, formando nuestro personal de salud. Ha sido una experiencia muy interesante, sobre todo en el área materno-perinatal, en donde hemos podido obtener de parte de este programa una ayuda muy concreta de formación de varias profesionales y especialistas de varias instituciones en Bucaramanga que están haciendo sus cursos, sus programas y que estamos generando una masa crítica importante de personas que van a trabajar por mejorar la calidad. Next one, please. También estuvimos en comunidades saludables, un proceso de ayuda y apoyo que nos vino muy bien, especialmente el año pasado cuando teníamos todavía una casuística muy grande en la pandemia. Logramos de manera mucho más técnica estandarizar muchos de nuestros procesos de vigilancia epidemiológica, de rastreo, de aislamiento, de generación de información, mucho más para la toma de decisiones, la posibilidad de contar con personas que nos ayudaran a llevar el esquema de vacunación, abrir las puertas en barrios, especialmente hicimos un trabajo muy grande en los colegios y nos ayudó muchísimo a que el índice de desempeño de nuestra ciudad en materia de manejo de la pandemia fuera uno de los mejores del país. Next one. Un ejemplo de ello, en esta última gráfica, next, please. Es, por ejemplo, es nuestra cobertura de vacunación. Hace un mes teníamos ya más de un 99% de nuestra gente, incluidos los migrantes, con al menos una dosis, más del 85% con esquemas completos. Y ya más de la mitad de la población ingresa en todas las edades con las vacunas de refuerzo. Creemos que este tipo de programas de asistencia técnica son muy valiosos para un municipio y estamos seguros de que con el fortalecimiento de nuestras capacidades institucionales, con nuestras mesas de trabajo, de articulación, de participación de la población migrante, vamos a poder seguir brindando experiencias al país y a los tomadores de decisiones éticas públicas para que podamos atender de una mejor manera esta circunstancia. Muchas gracias.
Thank you so much, Dr. Ray, for your presentation. So now I'm going to introduce Mr. Alejandro Diaz. Alejandro is a health project management specialist at USAID Venezuela Response and Integration Office here in Colombia. Alejandro has more than 7 years of experience in project management in the private and non-government sector, with a strong focus on public health programs, global expansion of the health sector. Prior to his arrival at USAID, he served as a proposal manager and global expansion in the health sector. Alejandro has a bachelor degree in government and international relationship and a master degree in public administration. So over to you, Alejandro.
Okay, so good morning, everyone. It's a pleasure to be here, share our USAID story, what has been our investments in migrant and health in the region, and kind of explain what are the underlying causes and our history behind our USAID support. So next slide, please. So as we've talked about earlier this morning with other colleagues, health systems are under a state of shock and constant adaptation. And the main drivers of this is, in first instance, migration flows throughout the region, and the extent to which health systems, but in general national governments, could anticipate migration flows will have challenged the capacity of health systems to provide adequate services and respond to a sudden increase in migration flows. There's also a capacity of local health systems to adapt and respond to sanitary shocks, mainly from COVID-19. We understand how both challenges from migration and COVID-19 merged and created an additional strain on local health systems. As a consequence, or in addition, there's a change in local disease profiles that have been driven by migration, the effects of migration, and the cross-border effects to manage disease, and the governance of health system service delivery. On the right, we can see where Venezuelans have migrated to. So this migration phenomenon in the region has not been equally distributed among countries. We've seen, for example, countries like Colombia or Peru host roughly 50% of migrants, which account for more than 7.5 million, according to latest figures. So again, the burden is not equally distributed, and there are cross-border challenges that we need to address. Next slide, please. So this is just a snapshot of how migration has increased in country, so that you get a sense in the last 5 years the extent of this increase and the pressure that this means in terms of health system response. So as you can see, For example, the jump from 2021 to 2022 were almost a 35% increase. Let's remember that in 2021, the government of Colombia issued the temporary protective status, which allowed migrants to have legal status in country and access services, among which, health is one of them. So we were able to account exactly how many people were living here and the magnitude of the issue and the challenges that the country faced. And just as migration flows increased, so did the provision of services. So before the temporary protective status, we can already see how the system began to respond to different needs of migrant populations, some of them on the emergency front, but others on the more chronic long-term service provision. And we also see there's a very steep increase in how the local health systems step up to address this increase in migration. Also, COVID-19, we also see that there were differentiated consequences among different LAC countries. So, for example, you can see countries like Colombia or Peru, where mortality rates and deaths per million people were way above South American averages. In other countries, such as the Dominican Republic, Honduras, or Jamaica, where even though there were vaccines available, there are very noted challenges to make sure that there was an efficient delivery and an equitable delivery of vaccines. Next slide, please. So now that we talked about the context, what are the two main drivers of these shocks? On the one hand, we have migration. On the other hand, we have sanitary shocks, mainly COVID-19. LHSS became a very relevant mechanism to try to support local governments in addressing, absorbing, mitigating, and responding to these shocks. So to date, at a regional level, LHSS has obligated around 40 million. And the main purpose of LHSS is not to create a parallel system. We are here, or the mechanism is here to strengthen what's already here, bring the resources, the expertise that local health systems need, and support them to respond and transition these capacities for this more longer-term response and preparation for future shocks. So regionally, we're in 4 countries, and there's one regional activity. In Colombia, it's called Comunidades Saludables. But there's also presence in Jamaica, Dominican Republic, Peru, and Honduras, where it's managed out of our LAC Bureau. So the scope and the reach of LHSS activities vary according to country needs. So if we go to the next slide, please, we can get a better sense of how this broader goal that LHSS brings to the table accommodates to each country needs. So at a global level, LHSS is a global health mechanism. LHSS seeks to support transition to sustainable, self-financed health systems to advance universal health coverage. So what does this mean at a country level? How do we bring this theory of change while addressing each country needs? So for example, in Colombia, there's a clear focus on how to integrate migrants into the health system and how to prepare the health system to future shocks. COVID-19 on the one hand, but also future migration shocks given the cross-border challenges we face in the Venezuelan region, in the Venezuela-Colombian border region. In Peru, there's a clear focus on HIV expansion of service delivery, and also a very specific line of work on COVID-19 support. The Dominican Republic, again, HIV service delivery and response to COVID-19 pandemic. In Honduras, there's a clear scope on how to increase service delivery, how to ensure protection and coverage, with a clear focus on a migration cross-cutting focus and a specific focus on women as well. And Jamaica, which had a very specific COVID-19 scope of work. So as you can see, HSS is very flexible in its nature and allows to accommodate to different country needs without disregarding what's the objective of supporting local health transition to universal health coverage. Next slide, please. So what's the country support strategy? So we can understand LHSS as a 4-dimensional model. And again, the relevance or importance of each one of them depends on the country needs and how each support is scoped out. But for example, in governance is one of the main pillars to support system strengthening. And countries like Colombia, Honduras, and Peru have in their scope of work how to include preparation to shocks into health policy. So it's not only migration, it's not only COVID-19, but how can we make the system more flexible by intervening at a health policy level? Then there's finance. So now that we have these guiding principles in our policy and our mandate, then how can we ensure that there's enough resources to actually carry out what's in local health policy? So again, LHSS works on how to mobilize new resources, how to make payments more efficient, how to transfer money more efficiently so that the distance or the gap between financing and service delivery shortens. And here, again, Colombia is a clear example with maternal health packages that they've formulated along with the Ministry of Health and local authorities, and Dominican Republic with HIV service delivery financing. Quality then comes to the table, access and quality. So now that we have the policy, we have the resources, how can we make sure that migrants or vulnerable populations can knock the door of the health system and come out better than how they came in? I think that's the main challenge here. How do we ensure that service delivery happens well and improves health outcomes? And again, Colombia, Honduras, Dominican Republic, and Peru have this in their scope on how to make sure on the HIV front, service delivery is appropriate, is effective. In Colombia, for example, and Secretary Rey mentioned it about the maternal and infant health pathway, the strengthening. And last but not least, which I think is a cross-cutting dimension, is how do we make the system more resilient? How do we make sure the system is flexible and is adaptive to local changes, many of which are sudden changes to context, many of which fall outside the realm of the health system. Next slide, please. So again, these are just some results. I'm not going to deep dive much into this, but for example, in Colombia, we understood that with the TPS rollout, enrollment was priority to make sure that migrants had this possibility to enter the health system for integral care. So there's an interesting result of almost 97,000 Venezuelan migrants affiliated through a number of enrollment campaigns that we've supported at a national and local level. LHSS Peru also formulated this roadmap to facilitate cross-border continuity of HIV care for Venezuelan migrants. So again, there's local impact, but also an interesting regional input for regional coordination. Next slide, please. In Honduras, again, locally owned roadmap to make sure that population at risk of migration, and specifically migrant women, were able to access social health protection. In Jamaica, again, with a very COVID-19 focused scope of work, there were 14,500 vaccine deliveries in country. In LHSS Colombia, another interesting result is the work that they've performed to bridge the gap between the community and the health system by strengthening community-based organizations. And then Dominican Republic, again, with an HIV scope on self-testing and how to make sure family HIV services were available to vulnerable populations. Next slide, please. So there are challenges, even though we've made great progress. The country has made great progress, and our technical assistance has been very helpful. There are still a number of challenges which I would like to highlight. The first one is that migration and sanitary shocks, to the extent they are a cross-border issue, they have the chance of spilling over to different countries, should have a government response. So we can strengthen the local level as much as we can, but greater efficiencies and greater outcomes will come when this greater integration and more regional governance is achieved. Migration flows challenge local health systems to become more flexible and resilient. I already mentioned this. Local health systems were accustomed to static populations, so there are a different number of assumptions for an efficient and effective local health care provision. Migration changes that and adds new variables that require health systems to become more flexible and adaptive. Xenophobia, but exclusion at all levels, continues to be an issue that hinders trust and performance of local health service delivery, but in the end, it questions the whole purpose of the health system, which is to serve the population in the country. And last but not least, health system strengthening efforts, to the extent they seek sustainability, must result in better health outcomes for the communities they serve. So during this transition and sustainability process, differentiating populations to achieve certain population-specific outcomes is okay, but in the long term, we should also be looking at what are the community-level outcomes that are achieving out of the resources and the expertise that we are mobilizing and we're bringing into the health system. Next slide. Okay, closing remarks. So health is a cross-cutting factor of migrant and returnee integration. Most of migrant needs start with health once they arrive in country, and health becomes a very cross-cutting issue along the socioeconomic integration of vulnerable populations and mobile populations. And that's not only the case for migrant populations who wish to stay, but also those who are in transit. We need a more prepared and resilient health system that sustain quality results. So once shocks happen, the big question becomes, how can we make sure that quality remains while the system is adapting? Number three, I think out of all of this shocks that we've seen from migration and COVID-19, there's an opportunity. USAID resources have this as a priority at a regional level, and we have to make sure that these resources are used or optimized in each country where we operate. But there is also a challenge, and I think that's where our support and our learning process as well with host countries on how to achieve long-term health outcome improvements. Again, I mentioned this. Mobilizing resources is important, is critical, is a very it's a much needed input and foundations for integration. As long as we are not addressing community level improvements and outcomes, then we may fall short in our support. And that's it. Thank you very much.
Thank you, Alejandro. Now for the Q&A and panel, I invite Alejandro, Dr. Reyes, and Kelly to join us on the stage. This part of the session will be moderated by Mrs. Kelly Saldana, who is Vice President for Health System Strengthening and Resilience with Abt Associates. So we'll have mics in the room, so feel free to just raise your hands. If you have a question, then you can just introduce yourself and ask your questions. And we'll also monitor the online chat for online questions. So thank you.
Thank you, Sophie. Thank you to our panelists. This has been a really great discussion. I think we probably have a full day's worth of content to cover, but so we're a little ambitious and trying to pack it all into 2 hours, but hopefully we can get a good discussion going with the questions. I remind the people in the room that we do invite you to lunch immediately after the session, so you'll have lots of opportunity to at least talk to our in-person panelists during lunchtime. So maybe if we focus now on questions for our virtual participants, that would be good. And just to sort of bring us back for a quick moment to why we're all here for the 7th Symposium on Health Systems Research, I am sort of struck listening to this whole thing about how relevant the topic of migration is to the topic of the Health Systems Conference. So I took a quote off the website that I'll just read because I really do think sort of the overall topic that we're discussing from health systems is fully embodied by the work that we're doing on migration. So what they talked about when they introduced the 7th Global Symposium is complex interactions between politics, policy, and service provision have translated into priority setting processes where vulnerable and already marginalized populations become more excluded from participating in decision-making processes. The ability that state and non-state actors have in influencing policy calls for reflection on how the concept of power must be considered in policy development, intersectoral approaches, and the role that communities and individuals play. So I think clearly figuring out how to meet the needs of migrant populations really fits within that intersection. So with that, do we have any questions from our online participants? I don't think so. Do we have any questions from the audience? Okay, well, I will never fear. I have questions prepared, so I will take the liberty to maybe kick it off. But one of the things that I'm struck with when listening to these presentations is really about how the different examples of health systems exhibited aspects of resiliency when they were able to address COVID-19. So we heard examples of how the ability was able to adapt to reach migrant populations with COVID-19 vaccines and information, as well as the ability of the health system in Colombia to absorb migrants into care and into their system. But when we talk about health systems resiliency, we really look for adaptive, absorptive, and transformative capacities. So I'm wondering if our panelists have any examples of where they've seen the health system really transform, where it's come out better on the other end because of having to figure out and address migrant issues related to COVID-19. So maybe I will start with our virtual panelists. I don't know if anybody wants to go first. Santino, go ahead.
Yeah, well, observing the situation worldwide, indeed, we have seen a lot of good intentions and good practices. Most of those good practices in strengthening resilience or capacity of the health system to include migrants, refugees, and other group of mobile population have been heavily pushed, and we broke up a taboo that universal coverage actually is possible and doesn't draw countries into bankruptcy. So this was extremely important. For the first time, it was easy to speak about including this group of population into universal coverage. The point is that I'm not sure this good intention has been transformed into changes for permanent improvement of sensitiveness of the health system to include this population. What I'm trying to say is that the example I brought before with the presentation on the access to vaccines, in reality, we observed also that when irregular migrants or the most vulnerable part of the population was asking to be immunized, and healthcare workers, the national system wanted to immunize these people, in many cases there was a mismatching because the IT platform to enroll population for immunization, they were not considering a population without document. So this person, they were unable to get any sort of access. How this has been resolved? We dispatching mobile immunization units around the city, around the country. The issue is, should we build up on this experience to eventually introduce changes, upgrading of the system in order not to face the same situation? Well, I'm not sure this is happening. So that's why we are so much insisting on building back better. So really not to lose the good experience and the good cases that we've been observing during the acute stage of the COVID pandemic. Thank you.
Mentioned. Does anyone else want to weigh in on that? I'm going to go relatively quickly because we don't have a ton of time. I do see a question from the audience, so go ahead. Feel free to ask in Spanish or English.
Thank you. Bueno, muchas gracias. Mi nombre es Rafael. Soy director de programas de Migrant Foundation en Colombia, donde se está implementando un proyecto con la cooperación de salud y del Departamento de Estado para las necesidades de salud en la atención primaria de los migrantes venezolanos. Estamos en 13 ciudades del país. Mi pregunta, tiene varios componentes. Digamos, sabiendo que los recursos son limitados y el acceso, el esfuerzo que ha hecho el gobierno colombiano por financiar el aseguramiento de los migrantes es importante. ¿Cómo desde las políticas de salud puede proponerse un enfoque de gestión del riesgo que realmente identifique, caracterice a los grupos o poblaciones de más riesgo para poder, digamos así, hacer más eficiente los recursos pocos que existen? ¿Y cómo se puede sostener esto también cuando sabemos que, pues, digamos, las dificultades fiscales de Colombia? Esa es una pregunta.
Sí. Would you like to take it?
I will respond in Spanish.
Sorry, I was going to have the representative from Colombia in the room respond first, and then we'll turn to you.
Bueno, de la experiencia de nosotros de ciudad, lo que vimos en esto que también que les expuse, es que hay un reto que es urgente y no es difícil. Colombia y su plan de salud pública tiene un ítem interesante que se llama focalización en población vulnerable. Hemos tenido experiencias muy bonitas de dedicarnos a trabajar con la población de discapacitados, hasta con los temas de problemas de enfermedades raras, obviamente con todo lo de comunidades indígenas. Colombia ha descubierto que esa atención diferenciada en términos de salud pública es importante. Y eso ha generado que la misma población beneficiaria pues se empodere, tenga sus voceros y nos ayude a organizar precisamente esa atención con gestión del riesgo. Creo que esos inmigrantes nos falta muchísimo. Nosotros sí tenemos esa expectativa que en esta formulación del nuevo plan decenal esta población sea mucho más visible. Vamos a hacer desde todos los actores del sistema de salud, tengamos ese capítulo obligatorio, que es lo que en parte nosotros con nuestras circulares hemos venido haciendo, y decirle a la institucionalidad que en materia de salud es grande, que hay mucho que hacer, pero que hay que ponerlos en la mesa y darles esa visibilidad. Creo que es el mensaje más importante.
Julián, would you like to add a couple points to that?
Sí, brevemente. Hay evidencia de que el costo de atender a los migrantes por enfermedades crónicas descompensadas por no tener acceso a atención básica es mucho mayor que el costo del aseguramiento. Entonces es cierto que a corto plazo esto representa un desafío fiscal, que es el aseguramiento de migrantes, pero hay que entender que muchos de los migrantes no tienen una pobreza estructural, muchos tienen competencias y fueron empobrecidos por la crisis en Venezuela, y probablemente con el tiempo muchos de ellos van a ingresar al régimen contributivo y ese representa un costo menor para el Estado. Pero definitivamente es mucho más costo efectivo incluirlos en el sistema que no incluirlos y tener que atender la emergencia. Y dos frases finales. Yo creo que incluir a las personas con un enfoque diferencial es importante, pero también es importante reconocer que los migrantes enfrentan los mismos obstáculos para acceder a los servicios de salud, al menos varios similares, que otras personas sin aseguramiento en el país más vulnerables. Entonces, creo que se puede correr un riesgo de que sea mal percibido que hagamos estrategias orientadas para migrantes por parte de las comunidades receptoras, sino más bien debemos conjuntarlas como ha hecho la cooperación internacional con las comunidades receptoras que tienen las mismas barreras de acceso. Y por último, secretario, en el decreto que en el anterior ministerio alcanzamos a dejar firmado, del Plan Decenal de Salud Pública, sí hay ya un componente de migración que esperemos que el nuevo gobierno nos siga desarrollando. Y la primera es que se incluyen los migrantes como una población en el Plan Decenal de Salud Pública 2022-2031, el cual quedó firmado y que esperemos que próximamente el nuevo gobierno nos retome.
Okay, thank you. Jairo, I wonder if you have any perspectives from the Ethiopian experience on this, given that certainly resources are a problem, risk to the population is also a problem, but it is a little bit of a different situation because it's internally mobile populations, but perhaps there's lessons to be learned.
Yeah, I think maybe specifically on the displaced population and the rehabilitation and supporting the health system to refunction. Again, I think the Ethiopian experience in engaging the diaspora community and also mobilizing local resources, however small those local resources can be, like for community-based health insurance, even supporting those members who are affected by conflict or different shocks to cover their contribution for 1 year, and so considering CBHI as a resilience mechanism for the community and those experiences, both in functioning the health system and also in sustaining the community-based health insurance. There are a number of lessons that we can learn and build on.
Thank you. Are there any other questions in the room? Okay, I have two more questions, one right here and then one in the back, and that's probably the final set of questions, and then we'll give each of our speakers a moment to make a 30-second final word after we do this round of questions. So please go ahead. It's on, I think.
Oui. Je parle?
Yeah.
OK. Merci, je vais m'adresser au monsieur qui a présenté pour l'avant-dernier présenté, c'est lui qui est à gauche. Oui, Alejandro, c'est ça?
Okay, a question for Alejandro?
C'est lui, à gauche.
For Dr. Reyes. Okay.
OK, merci beaucoup. Je suis docteur Hassan. Je viens de la République démocratique du Congo. Oui, c'est ce que je voulais. Alors, je voulais me présenter pour poser la question. Je suis docteur Hassan, je viens de la République démocratique du Congo. Je travaille comme directeur technique du secrétaire général à la santé et je suis chargé de la planification et suivi stratégique de la COVID en RDC, en République démocratique du Congo.
Él es el doctor Asani de la República Democrática del Congo. Él trabaja como director técnico del Ministerio de Salud y se encarga de la planificación y seguimiento estratégico a la respuesta a COVID.
Ok, merci beaucoup. J'ai une petite question. La première porte sur comment on a vécu la pression de la COVID dans les hôpitaux en Colombie. Et aujourd'hui, quand on a rangé le bloc des éléments, je pensais qu'il faudrait nous dire comment coordonner également la gestion des hôpitaux. Et qu'est-ce qu'on va préparer à la résilience des hôpitaux, qui n'est pas dit dans la présentation.
El doctor Asani tiene dos preguntas. La primera es, en Colombia, ¿cómo se vivió la presión COVID en los hospitales? Y la segunda es, cuando él recuerda que cuando mostraron la presentación del secretario que vio los 3 bloques, Me gustaría saber un poco más cómo se logró, cómo se coordina la gestión hospitalaria y cómo se garantiza la resiliencia y la sostenibilidad de esa gestión.
Sí, tenía que eso. La cuestión por decir la surveillance, cómo es el problema de la comunidad y el Consejo Nacional. Cómo de la comunidad.
La siguiente pregunta es, ¿cómo se coordina la vigilancia epidemiológica comunitaria y cómo lo articulan con el nivel nacional y cómo garantizan la sostenibilidad y resiliencia de esta coordinación?
Okay, I'm gonna have to cut you off there. That's 3 questions. I'm gonna do one in the back, and then we'll get answers and close up because we're almost over time. In the back.
¿Sí?
Sí. Oh, ahora no. Sí, ya.
Hola, hola.
Sí, ya. No. Manténgalo recto. No. Venga, venga. So, boys? Or just say it loud and I'm happy to repeat it.
Sorry, my question is quick and it's for Dr. Severoni. And the context, as Julian mentioned, is that in Colombia, the migration and the relation between migration and health and the gender is feminine. 70% of women, 70% of services that we are providing as health system go for women, especially in maternal and newborn health. So what is the approach of the World Health Organization on gender and health, specifically on women and health? Y si el secretario o alguno de ustedes también quiere hacer un comentario sobre las acciones y estrategias específicas para llegar a mujeres preventivamente, dado que pues, ustedes saben que ellas acceden a urgencias y no desde la prevención muchas veces.
Thank you. Okay, we're going to start with Dr. Juan Jose to answer the questions and give any final remarks that you would like to give. Then we'll go to Alejandro for final remarks, and then we'll go to our virtual participants, Dr. Santino, to answer the question for him and give any final remarks, and on to the virtual participants. And again, this has been a really great conversation, and I know we could go all day, but hopefully we've gotten a richness of this topic. So go ahead.
En esa preparación del país para atender la pandemia, incluso creo que el doctor Julián, que lo vivió del orden mencionado, también tiene mucho que aportar en esta respuesta. Definitivamente, las grandes lecciones que nos deja la pandemia, ¿cuáles están? Nosotros estábamos en un sistema de salud con muchos actores, muchas instituciones, quizás en muchos aspectos desarticulados, y en un modelo también de competencia que en ocasiones hacía que el diálogo y el trabajo de equipo no funcionara o no tuviera la fluidez que uno quisiera. Pero la pandemia nos dio una lección muy grande. De repente nos dimos cuenta de que nuestras instituciones de salud estaban dando la talla. Empezaron los intensivistas, los internistas a hacer sus redes, a hacer trabajos colaborativos, muchas veces espontáneos. Empezamos a ver que nuestro ministerio, la capacidad de liderazgo, la capacidad técnica y científica de sacar las normas, las resoluciones, que todos empezamos a creer, actuar al unísono, con muchas veces obediencia, con quizás una cultura de milicia, sabiendo que estábamos atendiendo una pandemia tan grave. Y tuvimos un cambio de de organización, de liderazgo dramático, pero al final nos dimos cuenta que sí podíamos. Creo que el país, para su segunda pregunta, debe, y debe aprovechar, hacer las reflexiones y las retroalimentaciones de los mensajes y de las transformaciones maravillosas que se dieron a pesar de un momento tan dramático. Creo que la salud pública debe retomar su protagonismo, su liderazgo. Creo que el país no puede retroceder en saber que al sistema de salud hay que apoyarlo también, especialmente a la salud pública, con los recursos que se requieren. Nos dimos cuenta que tenemos muchas capacidades y que tuvimos una experiencia maravillosa para articular, liderar y trabajar en equipo.
Muchas gracias. Alejandro.
Thanks. Yeah, so just as closing remarks, I would like to highlight again the need and I think the orientation of health system strengthening efforts towards sustained quality. I think quality is an indication of how strong health systems are and how they will be their performance in the event of shocks such as migration or COVID-19. So I think this is a field where I think us as USAID and other international donors, we should support local governments in understanding their quality measurements, specifically on migration, how migration plays a role in quality, and at the end of the day, see how our contributions and the resources that we've mobilized translate into better life for and better health for communities.
Thank you. Dr. Santino, please answer your question and provide closing remark. You're muted. You're muted, I think.
Thank you. I will try in a very short form. Well, the gender issue is obviously extremely important, but my first comment is that we should look at gender not only thinking about women, but also thinking to the entire population, which is representing the one moving. Perhaps there are situations where migration flows are mostly one gender, they're male, and there is an high risk related to masculinity or increased risk to be exposed to health issues related to masculinity. So the element of gender is extremely important, need to be sized according to the phenomenon, how it is manifesting. We have seen crises like migration from Venezuela or the Syrian crisis, and now also from other part of the world where we are having also household on the move. So we have also element of elderly and youth. So indeed, this is very important. The concern is that too often we are confronting with receiving countries not necessarily prepared to receive the situation of this package of challenges and problems, starting with the healthcare workforce, where probably more investment in defining and acquiring competencies as a basic package of competency that healthcare workers should have is extremely important and would be a step ahead. Regarding the concluding remark, in the interest of time, I'm running a bit, but I'm happy to continue this discussion on gender on a separate note. I think that today came out once more a very powerful message that a lot of very interesting initiatives are ongoing. So we are really appealing countries to invest more into quality research. We need to document what is functioning and what is not functioning. This is not yet at the level that should be. We really believe that more investment in describing, for example, what happened in Colombia, who was hosting the conference, what was the process, what were the challenges, what were the achievement in providing health insurance coverage to such relevant size of population, is extremely important if properly documented with a scientific approach and quality approach for other countries which are starting the same process now, or they're going to face this process later on. Thank you very much.
Yeah, go ahead. Can he not hear me?
Hi, are you listening?
Yes, go ahead.
Okay, just a quick conclusion from me. I'm gonna do it in Spanish in order to do it quickly. Primero, yo creo que debemos entender que mejorando el sistema de salud para las personas más vulnerables también lo mejoramos para los migrantes. Quiero insistir en esa idea. Los migrantes enfrentan en gran medida las mismas barreras de acceso efectivo a servicios de salud que otras poblaciones locales vulnerables. Y muchas de las estrategias que pueden ser útiles para los migrantes también lo son útiles para estas otras poblaciones. Entonces, constituye una oportunidad para mejorar el sistema en aquellas debilidades que todavía tiene, en aquellas inequidades que tiene, especialmente para estas personas. Una segunda idea, muy rápida también es, creo que es importante construir sobre lo construido, es una invitación, por supuesto con el sesgo de quien hizo parte del anterior ministerio, pero al investigador que nos preguntaba, yo solo quiero darle un hecho. Colombia pasó de tener 5.346 unidades de cuidado intensivo a 13.106 en semanas. Un sistema de salud que fue capaz de expandirse, integrarse, es un sistema de salud que tiene capacidades que tenemos que mantener y fortalecer. Y el secretario que está acá lo sabe. Entonces es muy importante esa expansión de unidades de cuidado intensivo que ningún país logró, como Colombia, duplicar. De hecho, fue 2.3 veces en tan pocas semanas. Y una tercera idea es, en el marco de las discusiones actuales sobre el sistema de salud con el nuevo gobierno, hay algo en lo que deberíamos estar de acuerdo. Salud pública. La salud pública está por encima del debate del aseguramiento y definitivamente el Plan Decenal de Salud Pública nos permite aproximarnos a los migrantes y a las poblaciones vulnerables por encima de este debate. Muchas gracias.
I can't hear you, Kelly. Should I proceed?
Yes, please.
Okay. Thank you. I think when we, for me, when we talk about mobility, I think internal migration, internal displacement, and also mobility because of the socio-economic condition is important. And when we talk about global migration, also addressing the push factor, be it the displacement, conflict, and other aspects are equally important. So for the West and for the developed countries, when they need to tackle the problem of migration, it should start from protecting displacement, migration, and the push factor from in the countries. From the health system perspective, I think like for the pastoral communities, there is a need to address health system issues in pastoral communities and also tailoring services to the needs of those specific segments of the population. And as I said, on the displaced people, rehabilitation, reintegration, and the refunctioning of the health system is important, and working in those areas is critical. And in doing so, mobilizing resources is definitely important, building resilience, including using local resources, but also the need for global partnership and collaboration in resettling and strengthening the health system is critical.
Okay, thank you so much. And thank you to all of our participants, our panelists, both online and in the room. As I said, it's a really fascinating conversation and topic, and we really appreciate you bearing with us. For those of you who are here, we invite you to lunch in the restaurant just outside the door. For the panelists online, we don't have lunch for you, or dinner, wherever you are, but thank you very much for your participation, and we will figure out a way to continue this conversation. And then just also a big thank you to the LHSS Colombia team for providing all the support to make today happen.